Hello friends, today's book reading chapter number 35 of Devita, carcinoma of the pancreas. So pancreatic ductal adenocarcinoma, that is the 11th most common cancer diagnosed in United States, with an estimated 60,430 new cases in 2021, but is the third leading cause of cancer-related mortality, with an estimated 48,220 deaths, and it is estimated that the incidence will continue to rise and that by 2030 there will be 88,000 new cases and 63,000 deaths, making pancreatic ductal adenocarcinoma the second leading cause of cancer mortality in the US. So pancreatic ductal adenocarcinoma is the seventh leading cause of cancer-related death, and the majority of patients newly diagnosed with pancreatic ductal adenocarcinoma presents with loco-regionally advanced or metastatic disease, with a resection is possible in approximately 10 to 20% of the patients at the time of diagnosis. Most patients undergo curative intent pancreatectomy will recur between 12 to 22 months post-operative. So there is recurrence in 12 to 22 months after pancreatectomy, and the pancreatic ductal adenocarcinoma remains an aggressive disease that is potentially curable in subset of patients with localized disease who undergo complete resection. So 5-year survival of patients with pancreatic ductal adenocarcinoma has improved marginally over the past 2 decades and currently estimated to be 10%, 3%, 15%, and 30% of the all stages metastatic regional and localized disease, compared to 4%, 2%, 5%, 12% in 1997. So survival has improved significantly, and as the data suggested that the largest improvement in survival has been seen in potential surgical population of patients, likely a multifactorial result of improved patient selection. So we have improved the patient selection, perioperative care is also improved, operative techniques, and multi-agent systemic chemotherapy in both the adjuvant and neoadjuvant setting. Since the last writing of this chapter, there have been no paradigm shifting advances in the systemic therapy for advanced or metastatic pancreatic ductal adenocarcinoma. PARP inhibitors have been incorporated in the treatment of patients with metastatic pancreatic ductal adenocarcinoma harboring tumors with deficiencies in homologous recombination repair of double-stranded DNA breaks, BRCA1 and BRCA2. So PARP inhibitors. PARP is poly-ADP ribose polymerase inhibitors. They have been incorporated in the treatment of metastatic pancreatic ductal adenocarcinoma who has this BRCA1 and 2 deficiencies. So immune checkpoint inhibitors have been shown some promising results in patients with microsatellites unstable cancer, but these patients comprise only a small percentage of those with pancreatic ductal adenocarcinoma. So this chapter provides a comprehensive overview of pathology, management of pancreatic cancer, focusing on pancreatic ductal adenocarcinoma, the less common type of pancreatic problems, pancreatic neuroendocrine neoplasm, and pancreatic cyst. So current management strategies and latest understanding of the genetic and molecular biology of pancreatic cancers is reviewed. Management of the pancreatic ductal adenocarcinoma require multidisciplinary approach that involves surgeons, medical oncologists, radiation oncologists, radiologists, gastroenterologists, pathologists, palliative medicines specialists, nurse, nutritionists, many others. And herein the roles of surgery, chemotherapy, radiation will be emphasized. So epidemiology, pancreatic ductal adenocarcinoma developed because of acquired genetic defect over many years, and therefore most often occurs in elderly, and most patients diagnosed between 55 to 84 years. And according to surveillance this year data, 7% of the patients diagnosed between 1975 to 2016 were under the age of 50 years. And overall incidence in US rise and is currently 12 of 1 lakh person years. affect men and women equally, with risk slightly higher in black patients as compared to Caucasians. So genetic risk factor, the greatest risk factor for pancreatic cancer is the strong family history, and approximately 10 to 15% of the pancreatic cancer family, they are familiar. So 10 to 15% is familiar. And defined as family history involving at least 2 first degree relatives, that is parents, offspring and siblings, and the lifetime risk is about 40%, that is 32 fold higher than the general population. 10 to 15% having strong family history, that is a lifetime risk 40%, 32 fold higher as compared to general population. For patients with 3 to 4 affected family members, and 10% for patient with the 2 first degree relative, that is 6.4 fold, and 6% for 1 first degree relative. The lifetime risk is 40% for patients with 3 or more first degree relative. If 3 or more first degree relative, then the lifetime risk is 40%. If 2 or more first degree relative, then the lifetime risk is 10%. And if 1 first degree relative, then the lifetime risk is 6%. Only a small proportion, 5% of the genetic defects underlying familial pancreatic cancer have been discovered. So hereditary breast cancer is most common familial syndrome and caused by genetic defect in BRCA1 and BRCA2. Other defects in DNA repair pathway that have been associated with the familial pancreatic cancer include PALB2, that is seen in 3% of the familial cases, ATM in 2%, FANCC in less than 1%, and FANCG in less than 1%. These genotypes include chromosomal instability and pancreatic carcinogens. So these are the familial link disorder predisposing to pancreatic adenocarcinoma. So first one is hereditary pancreatitis, that is caused by PRSS1 or SPINK1. Lifetime risk is 40%. Second is Peutz-Jeghers syndrome, LKB1. Lifetime risk is 30%. Familial atypical multiple mole melanoma, CDKN2A. Lifetime risk is 15%. Hereditary breast and ovarian cancer, BRCA2. Lifetime risk is 5%. Familial breast cancer, PALB2. Lifetime risk questionable. Ataxia telangiectasia, ATM. Lifetime risk 5%. 3 first degree relative with unknown gene. Lifetime risk is 40%. 2 first degree relative with unknown gene. Lifetime risk is 10%. 1 first degree relative with the pancreatic adenocarcinoma having lifetime risk of 6%. Thank you.